whether it is elastic or whether it is stiff. When there are benign lesions, they have more elasticity, malignant lesions have got more stiffness. We can use the transducer to do it, or we can also look for the adjoining blood vessel to cause a compression on the nodule, or we can give acoustic radiation force so that we can judge what is the stiffness of the nodule. This is an example of a 55-year-old man with a papillary carcinoma, an irregular hypoechoic lesion within the thyroid gland. The stiffness of the tissue is determined by the structural properties of the matrix. You can give a calculated value also of what the stiffness is. Benign lesions have more elasticity and less stiffness. Malignant lesions have less elasticity and more stiffness. Now, CT and MRI, they play an important role in preoperative evaluation of thyroid masses and in evaluation of postoperative or post-therapy changes. CT and MRI may be needed for further evaluation of incidental thyroid nodule detected on ultrasonography. These are normal appearance of the thyroid gland on CT scan. This is an axial image and this is a sagittal image. This is the right lobe and the left lobe and the trachea in between. Because iodine will be there in a normal thyroid gland, they show increased density or hyperdensity on CT scans, and this is a normal thyroid. But when this, for instance, like this multinodular goiter, if there is any lesion, of course, the normal appearance is completely changed and you can see a mass which will have variable kinds of density within it. When we do CECT of a thyroid patient, we should be little cautious, because when we give iodinated contrast, that contrast can cause a sudden bolus or spike in the level of the blood iodine. So, in susceptible individuals, there may be thyroid function disruption. It does not always happen, but in susceptible individuals who are maybe on medication for thyroid problems, there can be a problem in the thyroid function. So, not all lesions which we come for imaging will be a thyroid lesion. For instance, this 10-year-old boy with a nodule at the base of the tongue, which on CT scan showed a well defined cystic lesion. This is the sagittal image, this is the axial image. So, just from this we cannot say what it is. So, what we would do is proceed for a thyroid scintigraphy, where you can see that the region of the nodule is not showing any uptake, whereas the normal uptake is seen in the region of the thyroid gland. So, this is not a lingual thyroid, it is a thyroglossal cyst. But this patient is having a nodule which is dense on CT, which is hypo on in the MRI in T1 and T2 weighted images, and in the technetium scan it shows uptake. So, this is a case of a lingual thyroid. CT scan and MRI both are helpful in evaluation of the extent of metastasis in thyroid malignancies. For instance, this is a papillary carcinoma of the thyroid showing multiple nodal metastasis. This is a medullary carcinoma of the thyroid with multiple calcified nodal metastasis. You can see multiple nodes with heavy calcification in this one. This is a 19-year-old female with a known papillary carcinoma of the thyroid. The arrow over here is pointing to the small papillary enhancing lesion, papillary carcinoma. The right lobe is also enlarged compared to the left, and there is a cystic lymph node. So, in such a situation with the known papillary carcinoma of thyroid, we know that this is a cystic nodal metastasis. MRI of normal, MRI is not very frequently asked for thyroid lesions, but when we get them, a normal thyroid would show mildly brighter signal intensity than the strap muscles in T2 weighted images, and would be iso-intense to strap muscles in T1 weighted images. MRI may be useful in staging and assessment of recurrence of thyroid carcinoma, in localizing masses in conditions like lingual thyroid, thyroglossal cysts, etc., and also in evaluation of thyroiditis, where generalized enlargement of the lobes with increased signal in T2 and stir images are seen, and also in the evaluation of thyroid ophthalmopathy, MR has a significant role to play. This is an ultrasound image of a typical Hashimoto's thyroiditis in an 11-year-old boy. The thyroid gland is enlarged. We do not see the normal well-defined outline, and we see multiple tiny micronodules in the thyroid gland, which are due to lymphocytic infiltration. This picture, along with this hyperemia seen in the Doppler study, is indicative of a Hashimoto's thyroiditis. There is also an enlarged lymph node over here. In general, thyroiditis can show, like in CT scan, a diffuse enhancement of the thyroid gland, and also previously when we saw the normal thyroid, it was dense on CT. But here you see, because of edema in the swollen thyroid gland, it is showing low density on CT scan compared to the strap muscles. Here, after doing an I131 scan, there is virtually no uptake in the thyroid gland. This is a 48-year-old male who came with us with a history of pain in the neck and fever. We see that the thyroid gland is not extremely but mildly enlarged, but is also showing edematous signal, whereas normal signal is changed, and also there is a focal hemorrhage over here. We do not know if the patient had already had a cyst or a nodule there which had bled, but the rest of the gland is showing edema and thickening. This is the stir coronal images. Stir images are images which are basically suppresses fat in the body and highlights wherever there is edema. So, here the thyroid gland is thickened and edematous, more on the right side, and there is very poor and patchy radiotracer uptake because of thyroiditis. In multinodular goiter, generally imaging is not required unless the lesions are very large, and preoperatively you can look for the extent of the disease or the compression on the trachea as well as on the vascular structures. Multinodular goiters on MRI can be very heterogeneous in appearance. You can see how many different kinds of signal intensities are there in this enlarged gland. And because of this heterogeneity, it can be difficult sometimes to differentiate thyroid multinodular goiter from other carcinomas of the thyroid gland. This was a young child, 13-year-old male, who came to us with a swelling in the midline and little more towards the left paramedian aspect. We saw this mass in the thyroid gland, and also there were smaller nodules. So, we were wondering whether is this goiter or whether this is a neoplastic lesion. Patient went for a 99 technetium scan. This is a stir coronal image. You can see an enlarged lymph node also, and this is the mass. You see that there is moderate thyromegaly with large cold nodule in the region of the left lobe, and there was FNAC done, and it turned out to be a thyroid neoplasm. This was a young lady, 32-year-old female with a midline neck swelling. You can see it is bright on T2, bright on stir images, and low signal intensity on T1 weighted images, and shows rim enhancement in contrast enhanced study. Patient was euthyroid, and in 99 technetium scan, what was found was that there was a cold nodule in the region of the isthmus. We do not have the follow-up FNAC of that patient. Because of the heterogeneous signal intensity of large tumors, MRI may face a problem in saying whether it is a malignant lesion or a benign lesion, but you can do contrast studies and to see the vascularity of the lesion, which if it is hypervascular, it will go in favor of a malignant lesion. Also, we can do diffusion weighted images. If there is diffusion restriction in the lesion, it goes in favor of a malignant lesion. If there is no diffusion restriction, it goes in favor of a benign lesion. Also, MRI is very helpful in looking for metastatic lesions. This was a patient with a known CA thyroid, and patient had come for a pain in the back. What we find here is a metastatic lesion in the dorsal vertebra causing compression on the cord. This is a very old slide. If you see the date, it is 1996. This was a patient of carcinoma thyroid who presented with neurological deficits. When we did the scan, we found that the entire cervical cord was showing bright signal intensity, that means there was myelitis. But additionally, we can see the fatty change in the marrow of the cervical vertebrae, which is looking as bright as the subcutaneous fat on the Stephen weighted images. So, when in a patient in this kind of a scenario with radiation has been given for carcinoma thyroid, the only diagnosis would be post radiation myelitis. Another condition where the MRI will be helpful in thyroid patients is thyroid ophthalmopathy. Of course, these patients are sent to us mostly from the ophthalmologist, not from endocrinologists, but MRI can very nicely stage the stage of the thyroid ophthalmopathy, whether it is acute like in this patient where there is thickening of the thyroid of the extraocular muscles and also edema. If it is a chronic thyroid ophthalmopathy, the edema will subside though the thickness may be persisting. Also we can look where these are the two optic nerves. If the extraocular muscles are compressing the optic nerves, MRI gives a very good delineation of that. So both structural and functional imaging can be done with the help of various imaging modalities. For instance, this is a young child who came, a young boy, 18-year-old male. He came with a painless swelling in the base of the tongue. From MRI, we can assess that yes, this nodular lesion at the base of the tongue is most probably a lingual thyroid. But for confirmation, we will proceed for a technetium scan and we will come to the diagnosis that yes, it is a lingual thyroid. Also, technetium scans are more helpful than structural imaging when there are very small ectopic thyroids. We may not always be able to pick up multiple ectopic thyroids. Maybe they are sort of fused. If the one lesion is large, it may be difficult to pick up the other small lesion, but radioisotope scans will give us a accurate estimation of that. And when you combine the two, you combine structural imaging with functional imaging, then you will get the best answer. PET-CT is not a primary diagnostics tool in thyroid cancer, but it plays a significant role for prognostication, for evaluation of recurrence and metastasis, management and follow-up, and also assessment of medullary and anaplastic thyroid cancers. PET-CT can be used to diagnose a medullary thyroid cancer, as radioiodine scans are not much useful because low affinity of medullary thyroid cancers to iodine. There gallium-68 dotatate or 18F F-DOPA PET scans can be helpful. So, if a patient has elevated calcitonin or CEA levels, if there is an indication for PET-CT to rule out a medullary thyroid carcinoma. This is an example of an FDG PET in a papillary thyroid carcinoma. You see the uptake here, and this is the lymph node metastasis. This is an 18F DOPA PET medullary thyroid PET scan showing the medullary cancer of the thyroid and also enlarged lymph nodes. So, clinical, biochemical, imaging and histopathological correlation all have to go hand in hand to come to a final diagnosis and treatment for the patient. So, in summary, CT and MRI can act as adjunct to clinical ultrasonographic and nuclear imaging techniques in evaluation of thyroid lesions, but may not always be helpful in accurate lesion characterization. The structural appearance, the extent of the lesion, invasion of adjoining organs, they are all beautifully demonstrated. But we need to have a combination of structural and functional imaging. So, PET-CT and PET-MRI will be very helpful in these conditions to come to a proper diagnosis, and of course, clinical biochemical correlation has to always be there whatever imaging technique is being done. I thank you for your kind attention, and it was a pleasure to be here.
Thank you, ma'am, for your excellent deliberation and showing us the beautiful images. So if you have any questions, one or two questions we can allow because we are running late of time. Okay. So if you don't have any question, you can conclude the session. Thank you.
Questions or comments?
Question or comments?
Ask the chairpersons and the speakers, Dr. Rana Bhattacharya and Shumita Kundu, to please come to the back of the hall. We would do the memento presentation there so that the program is on.
As we move on to the next session regarding the IDEC course, it will be an online presentation by Dr. Shyamsundar Acharya from Newcastle, Australia. Over to Dr. Shyamsundar.
Thank you. Can you hear me okay?
Yeah, Shyam, you are well audible.
Okay, I'll just try and share my screen. Okay, you need to allow me to share my screen. Are you able to see my screen now?
Yes, sir. Yes, yes, Sham.
Okay.
You are audible and
Okay,
visible.
thank you. Okay, very good. Good afternoon, everyone, and welcome to this symposium once again from University of Newcastle. I'm sorry I'm not able to attend physically, but I'll make it next time. Um, I'm not able to see any one of you, but at least I'm happy that I can participate through this way. I've been asked to talk about our upcoming course, which we have been discussing it over many years now, but at last time has come for us to take this forward. In the next 15 minutes or so, I would like to briefly discuss advanced learning courses in diabetes and endocrinology, primarily aimed at primary care physicians from Newcastle University in association with Kolkata Hormone Foundation. So our University of Newcastle was established 1965. And we have additional campus in Singapore. Newcastle University is one of the top 250 universities in the worldwide ranking. Since 2014, we have been running a non-award certificate course in Kolkata. I think more than 150 doctors have richly benefited from this course. I'm proud to say that. All the thanks to all the teaching from Anirban, Devmalu, and Somya in relation to this. And COVID times made us think very deeply what's the sustainability of this program, which is taught face to face. How can we take this forward into an online digital platform which can reach not only audience in Kolkata but also across the globe? And this is the photograph, lovely photograph, when Anirban, Devmalu, and Somya visited us in Newcastle many years ago. That's one of our fancy building of Newcastle University, and that's a beautiful city of Newcastle. And these are some of the photographs from our past recipient of non-award certificate course in Kolkata. So why do we need this course? Can we not just send everybody to endocrinologist? Well, across the world, you all know how prevalence of diabetes and endocrine conditions have been exponentially rising, including thyroid and osteoporosis. People are living longer. Not only that, they are living with more comorbid conditions, which makes it very difficult to manage their conditions together. We have severe shortage of skilled clinicians, whether it is primary care or specialists. Countries like India have fewer than 1,000 endocrinologists who are mostly settled in bigger cities. That means outside capital cities, currently there is very little endocrinology workforce. And situation is not any different in Australia. We have less than 600 full-time endocrinologists in Australia. And again, most of us are settled in bigger cities, metropolitan cities, which means 1/3 of Australian population who live in rural, remote, regional areas do not have access to specialist care, which means they may have to travel several thousand kilometers to go and see a specialist, which is causing us a lot of problems. With the increasing aging population, incidence and prevalence, comorbid conditions, and rapidly changing therapeutic landscape, we are all finding it very difficult to be up to date with everything. For instance, in the diabetes field alone, there are going to be another 15 or 20 different types of GLP, GIP, myokine, all sorts of combination medications are evolving. How do we learn ourselves and how do we position them in the clinical practice is a big challenge. And our conventional degrees, whether it is MBBS, MD, or FRCP or FRACP, whatever we do, by the time people come out, they find it difficult to keep themselves up to date unless they attend a lot of conferences and constantly keep themselves abreast of knowledge through networking and active learning. These courses might help people who have finished MD to advance their knowledge further within the field of diabetes and endocrinology. The only way we can spread the specialist knowledge is through innovative service delivery and education. Otherwise, we are at risk of not able to treat people in the optimal way. So, specialist to non specialist, clinician capacity building through knowledge transfer, contemporary education models are needed. So that's why, with our 10 year of experience working in Kolkata, and not only that, in Australia, I've been working for the last 15, 17 years in the GP space in terms of teaching. And we have understood what they need to understand and learn. And therefore, with the combined expertise, we have come up with these advanced learning certificate courses in diabetes and endocrinology from Newcastle University. These are short, focused certificate courses delivered through something called Canvas Catalog platform. Once the candidate registers, they will get an online access, and at your own time, through preferably through a PC or a laptop or a tablet, you can access these courses. There would be optional summative tutorials, online tutorials, or maybe face-to-face once or twice a year as well in addition. And these short modules are 4 hours long, and the eligibility criteria at this stage is degree in medicine, but allied health is also welcome to join, particularly in Australia and many other countries. Allied health are taking increasing responsibility for patients in parallel to doctors. Therefore, we would be opening them up to those who have completed degree in nutrition and dietetics, podiatry, pharmacy, or registered nursing as a part
Recording
of
in
their
progress.
advancement in their learning. We would target general practitioners in Australia with the focus on rural and remote practitioners, clinicians in India, and also Pacific nations such as Papua New Guinea, Fiji, and other Pacific island nations to start with. We have planned expansion depending on the subscription volume to rest of the Indian subcontinent, including neighboring countries, Middle East, Africa, and broader Asia coverage over the next 1 to 2 year mark. These are very easy to navigate course. They are highly intuitive. If you can use smartphone, you would find these courses very similar to smartphone. They actually prompt you to go to the next step, and it's anybody can complete these courses through the platform. They are self-reflective, learning focused. One of the key problems we have seen is when people come for conferences, they listen, but they may not have reflective learning. This course is designed for audience to have a bit of reflection and think and learn. They have to retain their learning. That's an important aspect of learning in this way. These are highly practical. We know how busy every clinician is. Therefore, emphasis is on clinical, practical level and not really bombarding people with lots of guidelines which are sometimes difficult to mull through. There will be pre and post self-assessment, but no special exams. So it's all built in through the course. There is quite a bit of governance and quality assurance built in with these courses. Faculty is primarily drawn from University of Newcastle conjoint staff and affiliated experts. An editorial board will oversee the content development, ensuring information is current, evidence-based, and clinically relevant. And there will be a steering and governance committee which will oversee the program development and dissemination. We have emphasized that these courses will not only have to address the needs of matured healthcare societies such as Australia, but also very much the still developing healthcare systems across the globe. For example, people in Africa with type 2 diabetes at present may even have an amputation of their foot without ever being treated with metformin. I know people in Papua New Guinea have no access to glucometer. So there is no point in this course teaching only about GLPs or SGLT2 if the audience cannot practice that level of medicine. Therefore, we would have to tailor it in such a way that every country participant gets the benefit. I'm also very pleased to announce that we have obtained United Nations certifications for this course. Participants will receive a certificate of completion at the end of each individual topic. And at the end of completing all the modules, and there may be a comprehensive advanced learning certificate will be awarded. United Nations representative is involved in course development, and there will be endorsement from United Nations. We will seek further endorsement from Royal College of Physicians, Royal College of General Practitioners in Australia, International Diabetes Federation, and professional governing bodies such as Diabetes Australia once the module is prepared and launched. Finances, commercial courses are currently extremely expensive. 1 year course is around 7.5 to 10 lakhs in Australia. In terms of masters is about 17 to 20 lakhs. Of course, that is not what we are trying to do here. Therefore, what we have been able to negotiate is that this course will come from the goodwill of the faculty. There is no financial benefit for any of the faculties. There is no official source of input at this stage. However, we will charge the candidates extremely small token fee only, which could be something like 3,000 rupees per course. And there may be, again, resource limited countries, a full fee waiver is possible. For certain countries, scholarship may be given to them as well. And all the finances and registration will be managed through University of Newcastle website called Tundra. And of course, we are happy to take any professional donations or sponsorships to build this course. Again, faculty is not going to receive any financials, but the financials will be for administrative purpose, the Canvas catalog, subscription fee, and also any scholarships we may be able to give it to some countries. The proposed short courses include, not limited to, these are some of the endocrine topics we are working on. Thyroid disorders, we just heard a fantastic thyroid imaging talk. And imagine you would learn it a little bit more slowly, understanding, grasping, and through a reflective, the same thyroid imaging through this course where you can go back and review that. We have calcium disorders, electrolyte imbalance, adrenal disorders, pituitary disorders, bone disorders, pancreatic disorders, neuroendocrine pathology, trans health, reproductive endocrinology, maternal and fetal endocrinology, and menopause. And in terms of diabetes, from epidemiology, pathophysiology of diabetes, all the way through chronic complications, autonomic neuropathy, for instance, diabetic kidney disease, foot disease, inpatient diabetes management, diabetes pregnancy, obesity management, lipid management, and of course, the importance of clinical audit and quality healthcare in diabetes. All these modules will be built depending on the interest of the audience. The style and assessment course will be set up with the reading material. Perhaps we will have about 5 minutes of